Thank you, Physician Forum of India, for giving me this opportunity. I have the honor of introducing none other than Dr. Rajesh Malhotra. He is a graduate and postgraduate from All India Institute of Medical Sciences, Delhi, and he has been a consultant since 1992, and he has spent more than 40 years in orthopedics in AIIMS. He was a professor and head of the orthopedics at AIIMS till June 2023 and chief of JPN Apex Trauma Center AIIMS till June 23. He is past president of Indian Orthopedics Association, and he was running the only cadaveric bone bank in India at AIIMS Delhi. He has over 900 publications, and with today's lecture, 801 invited guest lectures. He has delivered several orations, and he is among the top 1% researchers in the world. He has, to his credit, 16 books and 64 chapters in the books. He has been awarded many awards like BC Roy National Award, Eminent Medical Teacher Award, then Delhi NCR Healthcare Provider Award, Eminent Medical and Health Education Teacher Award, Capital Foundation National Award, Rashtriya Gaurav Samman 2022, and he has many fellowships like bone banking and revision joint replacement from Australia, IOA traveling fellowship, AO Advanced Trauma Fellowship, Ranawat Fellowship, IOS Fellowship. He has been member of many national and international task force and consensus groups. He has worked on many topics in orthopedics like prevention of osteoporosis, DVT prophylaxis, peri-prosthetic joint infections. He has been member of advisory groups of ICMR on osteoporosis, RTA, and injury surveillance and musculoskeletal disorders. He has also been an expert on DVT task forces on bioengineering and stem cells. He has been a reviewer for over 24 national and international journals and has conducted several training programs on arthroplasty, trauma, and osteoporosis. He has, to his credit, he has performed several live demonstration surgeries in India and abroad. So there are many first to his credit. If I keep counting, we will go a long way. So I'll stop here and invite him for the lecture. Thank you, sir.
Thank you very much, sir. A very good evening to all of you. Thanks PFI, thanks Dr. Chauhan. The first time in my life that I'm excited at being the 848. That's the rank which I think where I stand today, and I'm proud to be the 848. Never before in my life I've had such rank, but I think this is unparalleled. It's been unparalleled affection I've received this evening, and I'm really grateful to all of you here to have come out to listen to me, and I'll make it worth your while. I'll tell you what I have learned in 4 decades of my experience, and I have in last 1 year alone delivered 6 orations, just telling people all over the country about what I have learned from my 4 decades in orthopedics at All India Institute of Medical Sciences. And I hope that I'll be able to convince you that I have not wasted my time there. So today we are going to talk about what is new about hip replacement. So most of the people perform hip replacement from back side, from the posterior approach, or from the side. And that is a problem when you can't see what is happening, you can't use x-rays, you can't be sure about leg length. You know, in hip replacement, the biggest cause of litigation is that you can't make the 2 legs equal. And then of course that may not always be accurate. And then you have to give a big, large incision on the gluteal region. You have to go through the gluteus maximus and big muscles in the hip area. And then the patient gets more pain, it takes longer to recover, and then the scar is not very good looking. You can't be sure whether the implant has been placed right. And then this is the kind of thing we have to put the patient in, this thing for about 3 months so that the patient doesn't dislocate the hip. But all these are things of the past. Now, it was very difficult for me to change at the age of 55 after having done 15,000 hip replacements from behind to the front. And because I was in the leader's position in the country, when I stood up and said, people, this is another way of doing it, and this has convinced me that this is the way to go. I've been able to train a lot of people. So now we do hip replacement from the front, and it has got a lot of advantages. Some people tell you you need a special table, you don't need. You can do it on an ordinary table, and then it has got no extra cost. And when I do this, I can always take the X-ray, which was very cumbersome when the patient is in the lateral position, and you can actually put your components very precisely and be sure that you're doing the right thing. And then of course, this is something which is, you don't cut any muscles. You just go between the muscles. It's painless. So I always wanted to do 2 things. One, to send the patient home the same day. And second, to somehow do both hip replacements at the same time. And that is what I'm going to tell you. So this was the first time in India after COVID that I realized that it was not good to keep the patient in the hospital for long. So I did the first ever daycare hip replacement. I called the patient from home, did it by direct anterior approach, and sent him home in the evening, and he could get into an auto rickshaw and go home. And it has been shown that it gives excellent pain relief, excellent walk, excellent scores, and then lot of studies in this is very fast becoming popular in USA. So now 45% surgeons in the USA have converted to this approach. I was the one to start it in India and popularize it, and now I think more than 50 surgeons in India are doing it. But then we have continued to do a lot of programs to show, and it has been shown that this is really painless. Not only that, the patient can drive earlier, and I'll tell you another very interesting story, and there are no precautions required. So I don't have to tell the patient, don't sit on the low chair, keep a pillow between the legs when you turn around and all. So that's a big, you are not actually dependent on the patient's, adherence to the protocol to avoid dislocation. This is actually a big protection against dislocation. And one of the big reasons which attracted me to this was the cosmesis. We get a lot of very young ladies. And I can tell you that with COVID, we have a lot of patients coming in with avian. This avian is different from the avian we used to get from steroid and alcohol. It's much more painful, it's mostly bilateral, and in some cases it's even associated with infection in the hip joint. Now, these young ladies coming with hip, which is destroyed, giving a big scar on the gluteal region is very disfiguring. So actually, I have now done about 50 cases where we give a bikini incision. So this is total hip replacement surgery performed through a just incision in the groin. So when the Times of India covered it, they said bikini hides the scar of hip replacement than it is, because I was at Ames at that time. But another thing, I don't see any reason why Indian women don't deserve to have their vanity and have a cosmetic scar from a hip replacement in case they need one. And then sometimes we get a patient like this, particularly in COVID, we saw patients who were lying at home, got bed sores, and now you can't have a hip replacement by a usual approach. And that's where, we have done it from the direct anterior, and you can see this is the same man who had a bed sore, and he's actually got his life back, actually even playing with his pets and having a great life, because there's hardly any risk of dislocation, it's pain-free and gives you the function. We do computer-assisted hip replacement like the knee replacement also, and then we have done some research and published a thesis. Then this is the thing about the patient satisfaction. The patient satisfaction among the patients who have had surgery by direct anterior is much higher, and then we are able to do both hips at the same time now. And so, is this the approach for India? These are the things we do, and these are some of my patients. And they can do everything possible with this approach, whereas it's almost a sin to think of a patient to do these things when it is operated by the posterior approach. Now, dislocation is one of the biggest problem with the hip replacement. So we have these newer implants which are called dual mobility. So they have, special articulation. This head, there's this plastic. So one movement is here. Then between the plastic and this shell, there's another interface of movement. So because of these two interfaces, they are very unlikely to dislocate. So that's another advancement. Third is a short stem. Now, because young people are getting hip replacement, they may need a resurgery. And when they need a resurgery, having a hip like this, which is very short, is actually a boon, because they can have a very conservative revision when it happens that, and then of course for direct interior, for minimally invasive, it's a very good approach. We have newer bearings which don't wear out at all. Ceramic is actually, if you rub this ceramic against the metal will actually get scratched, not the ceramic. They are so hard. They are called hardened ceramics, but the patients can play, can get involved in sports, they can do rock climbing, they can do everything with these newer hips. Then we have the 3D models. So we can actually, in a very complex case, we can make 3D model. This is a case of ankylosing spondylitis, severe deformity, fused spine like this. So we need a model of the entire spine and the pelvis and the fused hip, and we could actually do the surgery on the model to see what position it will be ideally suited, and then we could actually really replicate it during the surgery. So that is another thing, the same patient walking, severely disabled because of Frank's bond, very gratifying. The next one is of course the hip-spine relationship. I'll just try to make it simplified. If somebody has a very mobile spine in young age and he gets a hip replacement, and later on he gets spondylitis and his spine is fused, the hip can start dislocating. Because normally spine has some compensatory mechanisms to prevent dislocation. If the spine becomes stiff, those mechanisms are gone and you have to redo the hip. So now we have systems where we can actually have a patient who has got a spinal deformity and the hips which are deformed. So we can actually make the 3D models, we can correct the spine deformity. After correcting the spine deformity with surgery, we can actually do the hip replacement, and then you have a patient who's very happy and then is not at a risk of infection. The other thing which has happened, it's very common to have a pelvic fracture or an acetabular fracture in old age. It has been shown that almost 30% of these people will need hip replacement within 1 to 1.5 years. So what we do is, we primarily do a hip replacement. So if you have an old man, diabetic, osteoporotic, gets a bad acetabular fracture, we don't believe in fixing it now. So we have been responsible for causing a major paradigm shift. We do a primary hip replacement and have the patient up on his feet on the day one. He doesn't have to wait for the acetabulum to heal, and in case the fracture, this operation fails, he has to have a redo surgery. All that is taken care of. Several examples which we have published internationally to do in elderly people especially. Just go ahead and do a hip replacement primarily with different kinds of contraption, but give them a good life without being bedridden for any time at all. Multiple publications on that. So we have these newer cups, and they are actually very special cups which can be used after TB in the hip or after fracture in the hip, and they are really a boon. So those are the advances in the material which have made it possible for us to have the good results after hip replacement. Another development is 3D implants. So this was a patient who had surgery in a big hospital, and during this bony ankylosis or a fused hip of ankylosing spondylitis, the surgeon ended up doing this. You could make a 3D model, we could actually design a custom implant, and then we fitted it on the model, and then made a titanium implant again to be doubly sure fitted it on the model, and then we did this, and this was the first case of a 3D custom made implant in India, and this patient continues to do very well. He's having a good life at 5 years. Another advance is something called EOS. That's a machine which can actually take your x-rays standing and sitting, AP and lateral, in less than 30 seconds, and it can actually calculate everything, all spinal deformities, hip deformities, pelvic deformities. So you can actually plan your surgeries much better so that there are no complications and the results are good. And again, we have published these things. The 10th point is the revision hip replacement surgeries. This is a patient where hip surgery went wrong, her cup went inside the pelvis, and we have again these very special implants and we can do these very special techniques. This one has been devised by me, published in the best journals in the world, and this is called a sandwich technique, and you can get very good results. The other advancement is the virtual reality, where you can actually practice the surgery by putting the special goggles. You can actually use it as a training modality also to train surgeons, and that's come in a big way, where you can actually not only impart skills to the surgeon but also transfer those things and have a really competency-based simulation. So this is how the VR is now helping the surgeon. The computer navigation, we have been doing it for a while. Again, the companies are coming with the different ways to increase precision of the hip surgery by the computer navigation, and you can actually design everything, and you can plan everything here. The last point in advances is the robotic hip replacement, which actually again increases the precision to 0.1 millimeter of the planned surgery. So this is again something, but let me also tell you, it's the man behind the machine which is more important than the machine. So it's not the robot which is important, but then if you have the good plan, the robot will execute it perfectly. So to summarize, the approaches, the advances have been changing the approach to the hip, going from back to the front, daycare hip replacement, cosmetic hip replacement, doing both hip replacement with two teams at the same time. This is the first in the world. Nobody has tried it or done it. We put the patient supine on a table. I have trained people, both sides, we do it from the front. In 45 minutes, the patient is out with both hips replaced, and he can again go home the same day or the next day. Short stem, special cups, and then of course changing the hip replacement acutely in patients with bad fractures, rather than trying a surgery which then fails and then doing secondarily, so that the person keeps on suffering interminably in between, and then improving the functional outcome, reducing the dislocations like dual mobility, and then 3D printing and EOS. I thank you very much for your attention, and Dr. Chauhan, thank you very much. Since you said it's going to be on what is new in knee replacement, you have given me invitation for my next talk. I'll come back and tell you what is new in knee replacement. Thank you very much.
Friends, I am very thankful to Dr. Chauhan and his team, Physician Forum of India, to give me another chance to moderate one more session. So last week we missed the CME 848, but I want to disclose, although we all had a withdrawal syndrome, me and Dr. Tulsi, we had, to the extent, we conducted the CME 848A, you can say, at our level on the same topic. We recorded 2 sessions, 12 minutes and 14 minutes, same topic, the NPH and DPS. So if you want, we can share that video. So sir, it is 848 original now, that was A. I was reminded of Eklavya and Dronacharya, whatever. So today, my duty, pleasant duty, to introduce one of the stalwarts. The topic given is immunotherapy in cancer. So I was amused to see that 2 stalwarts from AIMS, they are now with us, giving us what is new in their respective field. Dr. Dipanjan Panda, although he also requested me to keep the introduction very short, and I am one step ahead, I'll keep it very, very short. So he's from AIMS, he was trained from Massachusetts to USA. When I was reading his interest of field, so believe me, I didn't find anything which was not included. If you say I can read, his areas of interest include GI and hepatology, oncology, breast cancer, bladder cancer, kidney, liver cancer, oral cancer, prostate cancer, ovarian cancer, thyroid, lung cancer, cervical cancer, blood cancer, including multiple myeloma, leukemia, lymphoma. So I was reminded what a all-rounder cannot do. All-rounder cannot be wicket-keeper. He can be wicket-keeper batsman. All-rounder cannot be a wicket-keeper. So he has not included dermatology. So maybe that is missing. Sir, all yours for immune treatment. Immune treatment in cancer, if I have to just give one more line. So immune therapy has been there for decades in dermatology, in many things. Vaccination is all immunology. So for cancer it is a new thing. And there are a few advancements like CAR-T, and he will be the best to guide us.
Thank you. And I really thank Physicians Forum of India to give me this opportunity. And in presence of Professor Malhotra calling me another stalwart is the overstatement of the year. But whenever I am in this precarious position, I was reminded by a quotation by Abraham Lincoln, who has saved many of smaller mortal beings like us. He once famously quoted, "Nobody is fit to become president, but somebody got to do the job." Thanks for this review. I agree that I cannot be, actually I wanted to be a researcher. I mean, after completing my DM Medical Oncology, I went to Harvard to do a research on breast cancer. It was some personal. After a year, my wife was at that time a young assistant professor at UCMS. She said that I don't want to go to USA, but you can continue. Now you must understand, leaving a 3-year-old kid at home and seeing your kid growing every day on Skype is not the best way. It felt very lonely back there. And also I realized, thankfully, that I I like research, I like petri dish, but more than that I like human being, I like the touch, I like that emotional connect. So after a year I told my boss at MIT, Professor Sengupta, who was also an Amazonian, he said, "I do not want to continue," and he was great and gracious enough. I mean, he spent close to $48,000 a year on my salary and everything, but he says, "Of course you should go back." I came back and joined at Institute of Liver and Biliary Science. I wanted to do GI and hepatobiliary oncology. And I'm a member of the HCC expert committee at INSL, which is remain my core area. But after 4 years, I had a difference of opinion with my illustrious director, Professor Sarin. He's a great man. We had a small difference about our intramural grant. And being an emotional Bengali on a fit of rage, I resigned. So once he resigned, then of course he told me anything. But you know, once you have said something, it is very difficult to go. Now, by the time I also purchased a flat, so EMI was going, and with a professor, UCMS was a great, but the salary doesn't become handy. Professor Malhotra would agree. So I had to get a job. And that time I realized my teachers are there with me, and it is also their prestige matter if a guy who has their student doesn't get a job. So they all pulled together and got me a job in Apollo, and since then I was there. Unfortunately, in our country yet, oncology, subject-specific oncology in private sector has not yet been developed. So we had to do others. But GI and hepatobiliary oncology remain my core area, and I'm working on that. Recently, INSL has published the new guidelines on hepatocellular carcinoma, and I'm the only medical oncologist on that. So that's my polite reply to the generalist idea. So. But he was right that immunotherapy is there for decades. In fact, vaccines are the first immunotherapy. So you can say hepatitis B vaccine is an immunotherapy against liver cancer. And we have been using interleukins, which I'll come shortly, for renal cancer. So basically, the paradigm shift which has come in the last 5 years or so was actually based on a research by two eminent scientists, Professor James Allison and Professor Honzo, who worked separately in 2 continents, 1,000 miles apart in Japan and in USA, but came with the same reports, which was initially published in Nature way back in 98, for which a decade later they got Nobel Prize jointly. So we'll come to that. So we all know that cancer is a complex disease which is characterized by uncontrolled growth of cells and expansion of abnormal cells in the body. The cancer-related mortality in the world is expected to reach 22 million by 2030, and I think it will cross cardiac mortality. And in the last half a decade or so, we have been treating cancers, and we have achieved some success. At BB Dixit Library, opened the first volume of Harrison. The chapter on oncology was 10 pages. The only drug was there with methotrexate. And acute lymphoblastic leukemia has a 5-year survival of 0%. From there, we have come a place where ALL has a survival of more than 98%. In some places like St. Jude's, it's 100%. At our own institute, Professor Shamir Bakshi has published paper where, in spite of all our difficulties in following up, we have crossed 80% or more. So this conventional treatment of surgery, radiotherapy, and systemic therapy, that is chemotherapy, is very much there. But over the years, we have also shifted to some targeted therapies with antibodies and small molecules, hormone therapies, and immunotherapy, which basically targets the induction or augmentation of anti-cancer immune system. And in past few decades, they are gradually emerging as an important treatment option for several types of cancers. So what is cancer immunotherapy? In a nutshell, immunotherapy is a treatment that uses a person's own immune system to fight cancer. And it can boost or change how the immune system works, so it can find and attack cancer cells. So how does exactly immune system work in cancer? So I always tell, instead of looking at it, remember your second professional textbook of microbiology by Panikkar, an excellent textbook. Or if you have a little more enthusiastic reader, there was a textbook of essential immunology by Ivan M. White, where they basically describe how an immune system works when a bacteria or a foreign antigen enters the body. So it gets engulfed by a macrophage or dendritic cells, which process and with an MHC class 2 antigen presents in front of a T lymphocytes. So the T lymphocytes then divides or changes into 2 types of cells. One is called effector T cells, and there is an helper T cells and a killer T cells. The helper T cells or the CD4 cells then affects 3 types ways. It also directs the B cells, which change into plasma cells and secretes antibody which coats the antigen and leads to opsonization. The T4 cells also self-perpetuates the line, and it also creates a cells called memory T cells. Please remember that, memory T cells, which remembers. So there was a great movie called Cuba Gooding Jr.'s, and whereas a son writes in his radio, a son always remembers. The T cell, memory T cells, is a very important part of our immune system because it remembers. And of course, there is another cell called killer cytotoxic T CD7 lymphocyte, which directly kills. So this flux ultimately leads to killing of the bacteria. Now it is same with the cancer cells. Once cancer cells enter our body, the macrophage or dendritic cell can engulf them, opsonize them. There is a cascade of T lymphocytes which activates the B lymphocytes, kills. Then the question arises, why cancer cell grows if our immune system can detect and kill them? The reason being, the immune system, although plays a critical role in eliminating tumor cells, but this interplay, there's a complex interplay, and as the tumor acquires the ability to evade the immune system, so this interplay refers to immunoediting. So there can be an area of elimination where the immune cells eliminates, but gradually the cancer cells are able to convince our immune system that we are your own phase, and ultimately there is an escape phase. So the key concept is cancer immunoediting explains the homeostatic relationship between the immune system and a tumor. You can think of it as a stealth bomber cells. where the radar cannot detect the aeroplane which is coated with a stealth is, so that there is no reflection, or people who are more fond of watching movies, if you remember the Harry Potter's movie where there used to be a cloak, if you can put the cloak you become invisible. So the immunotherapy is an innovative treatment which dynamically modulates the immune system to attack cancer cells. So it basically used to strengthen the immune system, and it basically breaks this chain where these cancer cells can present themselves as our own, or they downplay the immune system. So one of the most important reason of downplaying the immune system is our T lymphocytes called T regulatory cells. So what are the functions of T regulatory cells? I'll be going quick. The T regulatory cell is the head of the family. Say if two brothers is fighting, the father comes and say do not fight. So T regulatory cells are there, which whenever there is a chance of increased immune reactions between the antigen and antibody, they suppresses that. And cancer cells upregulate the T regulatory cells to downplay our immune system to make the immune evasion. So these T regulatory cells, which is along with prostaglandin E2, transform fibroblasts and other interleukins like IL-6, IL-10, transforming growth factor beta, ground-side colony-stimulating factors, many things ultimately lead to a cause of tumor escape mechanisms. So if you are looking at the tumor cells, they have a lot of receptor ligands, and the immune cells also a lot of receptors and ligands. So the most important receptors on immune cell is a receptor called programmed death receptor 1 or PD1, and the similar ligand is programmed death receptor ligand 1. So when the PD-L1 and PD1 interact, the immune system recognizes the cancer of their own and they do not kill them, and now the tumor escape mechanism happens, the immune escape, and the tumor continues to grow. So the Professor Honjo and Professor Allison showed that if we can break the bond, the immune system will recognize the cancer cells as a foreign, and once they recognize it, voila, then it can kill it. And it is a much better system because immune cells are present everywhere in body. It doesn't actually require a lot of blood supplies because cancer, conventional chemotherapy needs a blood supply to carry those things, but immune system has a better way. They are present, omnipresent. And secondly, because of the memory T cells, once they recognize cancer cells, they recognize this and they continue to build an attack on that. So, unlike conventional chemotherapy where the effect abolishes or subsides as soon as we stop the chemotherapy, we have seen the effect of immunotherapy last longer even if the treatment stops. So even if we have stopped immunotherapy for various reasons, the patient continues to have a cancer-free time. This is a unique ability of immune checkpoint inhibitors not seen hitherto with conventional chemotherapy. So very quickly, these are the basic. My introducer was saying that it is there. Yes, therapeutic vaccines were there, cytokine therapy was there. We are using interleukins and interferon for decades, from dermatologist, rheumatologist, even cancer system. You know, I was a resident at All India Institute during 2005. We used to use interleukin 1. Used to be very toxic. But they showed the first drug which showed that cancer can be cured, especially in renal cell carcinoma. Adaptive T cell transfer, where you are taking the T cells out of the body, processing them against a particular cancer, re-injecting them, has shifted the way the hematological malignancy is being treated. That is called CAR T cell therapy or chimeric antigen receptor T cell therapy. And it's an expensive therapy, but it is coming in India and is holding a key and some say may completely replace bone marrow transplant or stem cell transplant in coming days for acute leukemias. So cytokine therapy like interleukins and interferons, they basically are cytokines which stimulate the immune effector cells, and their treatment for metastatic RCC I have already explained. Therapeutic vaccines. So this drugs is not available in India, but in USA and North America, there is a drug called Sipuleucel T, which is approved for the treatment of metastatic castrate resistance or hormone refractory prostate cancers. What we do have is, of course, human papillomavirus vaccine, which is being treated for preventing cervical cancers. This adaptive T cell transfer is a stimulation of native T cell by dendritic cells and genetic engineering of T cells to produce chimeric antigen receptors, CAR T cells, which are already discussed for the treatment of hematological malignancy. But today, the drug we are medical oncologists are using day in and day out, and it has actually made a paradigm shift. So the word paradigm shift is more often used and abused, but in any field of medicine, the paradigm shift happened maximum once in a decade. So the first paradigm shift in medical oncology happens in my time when the drug Gleevec or imatinib came in early 2003-2004, which transformed the way CML is treated and brought in a host of tyrosine kinase inhibitor. The next paradigm shift showed the monoclonal antibodies of rituximab and trastuzumab, which changed the way breast cancer and lymphoma are getting treated. And I think the third paradigm shift has brought an immune checkpoint inhibitor, which has opened a new vista. So as I explained you, immune checkpoints is basically the immune response is controlled by stimulatory and inhibitory checkpoints. There are two key inhibitory checkpoints. One I have explained you, that programmed death receptor ligand 1 and programmed death 1. And second is cytotoxic T lymphocyte associated antigen 4, which is antigen presenting cells, that is the dendritic of macrophage, along with the T cells. They basically causes the stimulation and inhibition of the T cells. So once what this inhibitor does, it basically block this. Once they block the PD-1, PD-L1 interaction, then these cells, T cells, suddenly recognize the tumor cells as a foreign cells. And then it basically starts a chain reaction which ultimately leading to destruction of cancer. So the basic funda is very, very simple. And it is an attractive therapeutic target because it is overexpressed in a wide range of tumor types. But not in all tumor type it is explained clearly. So melanoma, it is widely expressed, so it works very well. But in pancreatic cancer, it is not that way expressed. So that's why you will be finding many of the cancers we are using this immunotherapy, and many of the cancer it is not yet used properly. So the reason being that, so this is a drug called durvalumab, which is we used in lung cancer, especially after surgery and or chemoradiation. It's a PD-1, L1 signal blocker. So these are the basic difference. These are the drugs, all are available in India. So ipilimumab, nivolumab, pembrolizumab, those are difficult tongue twisters and jaw-breaking names, but they really do work. And they work in a host of diseases called head neck cancer, Hodgkin's disease, triple negative breast cancer, hepatocellular carcinoma, and they work. I have seen at least few patients whom we have lost hope, and they responded to one young female with refractory Hodgkin's disease. She was a mother of 3, and a relapsed refractory Hodgkin's lymphoma is one of the most difficult treatment. And post nivolumab therapy, she is cured. There was a young engineer I tried on with lung cancer, 32-year-old. He only received 6 cycles of pembrolizumab. After that, his company, the NTPC, said we cannot give any further. But he's still cancer free, and that shows that memory T cell concept. Not all patients respond so well, but at least 20 to 30% of his cancer, especially who has an overexpression of PD-L1, will respond. So this is I'm trying to tell you. So pre-IO era in stage 3 cancer, it was a 15 to 25%, 5-year survival, which has become 40%. And the overall survival, the stage 4, which was less than 10%, has now become 30%. So it is not 100%, but this you must have read in the newspaper, and many patients in a phase 2 trial in rectal cancer, they use a drug called dostarlimab, and in 16 out of 16 patients, they didn't find any disease. Now, Glaxo made this a sensational and it should not have been done, but it has shown that in a particular subset of rectal cancer, if which is MSI or microsatellite instability high, immunotherapy can actually do away with chemotherapy, even radiotherapy. Now, not all patients, but some patients. And as a physician, it is our duty to find out. They are not without adverse events. There are a lot of adverse events. Fortunately, the adverse events happen to not more than 5 to 10%, but in 1% they can be life-threatening also. I have lost one patient on immune-mediated pneumonitis. So basically, autoimmune reactions can happen in anybody. Commonly we see drug rash, hypothyroidism, but they can have a serious problem. So diarrhea, colitis, pneumonitis, dermatitis, hypophysitis, hepatitis, any itis, you name them and you can have them. And you have a presentation, generally they are with response to steroids, but in few patients we had to give infliximab also. So these all less common but more serious, like there was elevated serum creatinine, vision change, neurologic issue, cardiovascular issues, anything can happen, but fortunately they are rare. And there are typical timing when happens, the rash happens usually early, and the liver toxicity happens late, the diarrhea and colitis in between. And most of AEs are reversible with immunosuppression and steroids. So, I don't want to delay the dinner. So, the conclusion, ladies and gentlemen, that immunotherapy is the treatment using body's own immune system. Out of various types of immunotherapies, immune checkpoint inhibitors is at present seems to be the most wide range of action, but they are not the only immunotherapy. From tumor vaccines to CAR T cell therapy, everything is immunotherapy. For medical oncologists, at least the immune checkpoint inhibitor has made a paradigm shift in cancer treatment. The biggest advantage of immunotherapy, in my opinion, over conventional chemotherapy is the stimulation of memory T cells, leading to long-term immune stimulation in tumor control. However, please remember this, cancer cell survival mechanism and crosstalk is more complex than we think, and not all patients respond to immunotherapy. And ICI can have a rare life-threatening autoimmune reactions. Cost, availability are also major obstacles in a country like ours. So with that, I thank you all. And with sad leading, we'll be happy to answer the question to the best of our knowledge and ability. Thank you.
Can we have the turntables, please? Yes, sir. Turntable. We can't see that.
Dr. Chauhan. Friends, we had two wonderful sessions. One on, I'm very sorry sir, I thought it was on me and therefore we deserve another session on me. It actually happened to be on hip, so it was a great presentation. And immunotherapy sir, Dr. Dipanjan, we will have to one-on-one sir, someday I will come on a lunch in Apollo and try to understand from you sir. Honestly sir, honestly. Sir, I think we had two great sessions and therefore I will ask Dr. Bhadva to start question and answer sessions on the first presentation by Dr. Rajesh Malhotra sir. He will start the question answers and then we'll take it to everybody else.
Thank you very much, Sushil. Now the house is open for questions. I'll ask one question to Dr. Rajesh Malhotra. Is mortality more 1 year or subsequently after hip surgery?
So, thank you very much for that question. It's very important, and that brings you to a topic which is very close to my heart. The hip replacement is not necessary to increase mortality. It's a subset of patients who have osteoporotic hip fracture, for whom either hip replacement or fixation is being done, who have a very high mortality, not because of hip replacement or fixation, but because of the osteoporosis. And we call it hip attack. Just like you have heart attack and the brain attack, in order to emphasize upon the patient and his relatives about the seriousness of a hip fracture, we tell them that even in America, with the best care, 25% patients die before burial. So it's when it's a hip fracture, we are very worried, and you get good results if you operate within 24 to 46 hours, 36 hours. If you operate after 48 hours, the results start getting poor and the patients start dying. So much so that the NHS will give special financial incentive to the hospitals which are doing a hip fracture surgery, replacement or no replacement within 48 hours.
Thank you, sir.
But doctor, in this particular case, the patient's age is 94 and patient has a pulmonary tuberculosis with pleural effusion along with osteoporosis, fracture and other thing. So which will you treat first? Pulmonary tuberculosis, pulmonary effusion, or go for a surgery?
Sir, the hip fracture is...
Taking age into consideration.
Hip fracture is an emergency. The only reason you will not operate on a hip fracture immediately is a patient who is in a cardiac failure. Anything which is life-threatening, otherwise hip fracture has to be operated. I'll give you an example, sir. I had a patient who was 75-year-old, came from Singapore to attend a function in Delhi, fell down and broke his hip. Now, he didn't need replacement, he needed fixation. He was on clopidogrel. So the anesthetist said, we want to wait for 5 days. On day 3, he got ARDS and he landed in ICU. And after 2 weeks, when he stabilized, we shifted him from ICU, fixed his fracture, shifted him back to ICU, and then eventually he got better, and then he lived for 10 years after that. So you don't wait, everything else can wait. It's like this, sir. If you have, say, tuberculosis in a pregnant lady, would you start treating tuberculosis, or would you just say, you deliver and then we'll take care of the tuberculosis after that? It's like that.
Taking age into consideration.
Sir, age is the reason why there is an emergency. If a 25-year-old has a hip fracture, it doesn't matter. You can make him wait for 6 weeks, 4 weeks, doesn't matter. It's because of that age when they get bedridden and they start getting, you can get bed sores in 4 hours. You can get pneumonitis, you can get DVT, you can get UTI. So, I mean, you are really playing with fire here. So that's why the first thing we do in a patient with hip fracture is, if we don't treat your mother, father, they'll die.
Sir, Dr. M.P.S. Gandhi has a question.
Sir, how common is redo hip replacement surgery and its indication? And what about all your implants? Are they MRI compatible? You said different types of implants are there.
Absolutely, sir. These are great questions. So redo surgeries are becoming very common. So I wanted to tell you that, I mean, modesty aside, nobody in this country has done more redo surgeries than me in this country. So I already have operated on my first patient of redo surgery who was told that only Dr. Malhotra in this country can operate on me. But it's not that. We train all our students to do redo surgeries because the medicine cannot be slave to one person. But redo surgeries are very common, and they are becoming common because the hip replacements are becoming common and knee replacements are becoming common, and they are getting done at younger and younger age. So if somebody at the age of 40 now because of COVID and a severe AVL gets a hip replacement, there is no hip which will last 40 years. So now more and more failures are coming. We are training more and more people for redo surgery, but I'll tell you, of all the joint replacements who are being done worldwide, 10% are redo surgeries. And redo surgeries are complicated with 5 times higher risk of all complications, at least 5 times higher. And about your other question about
MRI
compatible, all implants which we use, the imported ones are MRI compatible. I don't use Indian implants at all because I think joint replacement is a major surgery and you can't have a failure occurring because of a bad quality implant. I would much rather tell the patient, I won't operate on you than to put an inferior implant. Same thing about, say, plate for a fracture. If you put an inferior quality plate and the plate breaks before the fracture heals, it will also be a redo surgery. But look at what patient had to pay in terms of suffering and the cost of redo surgery. If you put the right implant in the first go, that would have been a big favor to him, even if it is more expensive.
Sir, one more question. What exactly do you mean by hip fracture? Is the fracture of the pubis or the ramus, does it also, because in
That's
that,
again
I think
very-
the conservative treatment is the best.
That's again a great question, sir. So a lot of times I get to hear from, it happened to Dr. Julka's mother, if you know Dr. Julka, the famous oncologist.
Yes.
So he got a phone call, my mother has fallen down and she is having severe pain. I said, is she able to stand? Then she is able to stand. I said, then I'll come during the break. But if she can't stand, I'll come right now. She had a pubic ramus fracture. Similarly, by a fall, you can have a sacral fracture, which will not be seen on the X-ray. It will be an osteoporotic fracture, will be seen only on a CT scan. We are not worried about the fractures which don't make a patient bedridden. So if a pubic ramus fracture, a sacrum fracture, patient can get up and walk. I get worried about a neck fracture, an intertrochanteric fracture, with which unless you do immediate surgery, the patient will be bedridden and that patient can land into complications very soon. And let me tell you, I tell the patient relatives, this is a potential killer. Even if I do my best, there is 25% chances the patient will die within 1 year, and they will not die because of orthopedic problem. They'll die because they'll get acute kidney injury, they'll get pneumonitis, they'll get something. So for old people, it's really a death bell. So we are very, very aggressive about treating any old person who gets an osteoporotic hip fracture because it's a matter of life and death. Relatives think, थोड़ा सा पैर फिसल गया था जी, बाथरूम में गिर गए थे. So it fractured the largest bone in the body, and this is a hip attack. So you understand, equivalent to heart attack and equivalent to brain attack. So this is what we are talking about. So we are very, very aggressive. So unless it's something which can be sort of optimized within 24 to 48 hours, like for example, most of these patients, they don't even know they have diabetes, high blood pressure or uncontrolled diabetes. They fall, they come to us, blood sugar is 500, 450. So that we can control with insulin, so I can wait for 24 hours or 48 hours, but not more than 48 hours. So this is how it is. Unless it's something which, so if a patient is on clopidogrel, now the anesthetist will give GA and not give spinal, we'll still go ahead and operate. But provided the patient's relative agree. There are 3 kinds of risks in that. Mild risk, we will not ask them, we'll go ahead and operate. Severe risk, with the risk of death on table, we won't operate. When it's a moderate risk, we tell the family, they have to take a call whether they want to go ahead with the surgery or not.
Sir, there's an 87-year-old patient, she slips, and in the X-ray, now after the patient has slipped, you can't ask the patient, "Zara khade hoke dikhao if you can stand or not," because she's in pain. So she was transported to the hospital, the doctors did the X-ray, there was a clear-cut break, fracture of the ramus pubis. Now in that case, would you operate or you will not operate?
There is no question of operating. Now I'll answer it in 2 ways. One, you can't make the patient stand, but you can ask the patient, can you lift your leg up? The patient will not be able to lift the leg up if the hip is fractured. So that immediately initial thing is, then you can even ask the patient to stand up. Nobody can lift a leg up straight if the hip is fractured. So that is the first thing to ascertain that whether it's a hip fracture or not. Second thing, for a pubic ramus fracture, people in West are operating. They are doing percutaneous screw fixation under local anesthesia. I don't think there is either need or the really medical indication to do that in our patients. As long as your patient can get up and walk, They'll need a walker for a few days. You give them a walker, let them walk around, go to toilet, the pain will disappear. Nobody is bothered about the malunion of a cubic grammar, isn't it? So, but they are doing it percutaneously because, see, we have so many patients, we have no time to spend on a pubic ramus fracture. Now, if you get one patient in a day, it's a pubic ramus fracture, you'll find out ways to operate and put a screw there. Personally, I'll neither do it for anyone, nor recommend, or nor I'll get it done for myself.
Dr. Malhotra, sir, one of the indications of operating upon a hip is severe osteoarthritis of the hip. And some of these people who have severe osteoarthritis also happen to have osteoarthritis of the knee. Now, if my patient has got bilateral OA knee and bilateral OA hip, which one to do first and why?
So, excellent question. So, first thing is, one, it's our job to find out what is causing pain to the patient. So, many times we see rheumatoids, they have hip involvement, but hip is not so painful, the knees are painful. So, we don't operate on a joint which is not painful. I would much rather fix a joint which is giving trouble to the patient. Now, if hip and knee both are painful, then as a rule, the hip should be done first before the knee. If hip and knee both need replacement, first hip should be done, then knee should be done. Otherwise, whatever is hurting, whatever is troubling is the patient is what we see. We don't operate on radiological abnormality. We don't, I tell the patient, I will not operate on the X-ray. I'll operate on you. And I'm bothered about what is troubling you and not how it looks on the X-ray. Many times the patients is so classical about ankle. People with old ankle fracture has terrible looking X-rays, but they have no problem. They walk around normally. What is your trouble? If he is fine, let you, I think, find some other patient, isn't it?
Sir, one of the indications of operating upon a hip in a young patient is juvenile rheumatoid arthritis.
Absolutely.
Sir, what happens when you operate on a hip with juvenile rheumatoid arthritis, very severe juvenile rheumatoid arthritis, because the underlying process remains the same, the pathology remains the same. Does it affect the hip that you have replaced?
In fact, sir, interestingly, if you look at patients with arthritis and those without arthritis, the hip scores of those without arthritis are much better than those with arthritis. Their function is poorer than those without arthritis. Their scores are poorer, but they are happier. Because for them, the improvement in quality of life is so much more. And secondly, the joint lasts 10 years extra in an arthritic patient than a non-arthritic patient. Because a non-arthritic patient becomes normal after hip replacement. He runs, he uses. Those with multiple joint involvement, they have poorer scores, more satisfied, and they use it less, wear it out less, and it can last 50 years, whereas it will last only 20 years in a patient who doesn't have polyarthritis. So I have no hesitation. I have operated on 18-year-old patients because they were bedridden with both hips and both knees being involved. And it's unfortunate that in India, the rheumatology in the remotest corner of the country is not so good, because in West, you don't have any more joint replacements because of arthritis. Because arthritis is detected early, disease-modifying drugs are instituted early, and they never land into the end-stage joint disease. Unfortunately, we still get patients bedridden for 10 years, both hips, both knees, badly damaged, and I would also like to tell you, I was the first one in the world to do all 4 joint hip replacements together in one sitting, in one anesthesia. Both hips and both knees. And we have done it 6 times more. We have published the first case after it completed 6 years. And if I just take a picture here and post it on my status saying, I had a great evening today with the PFI in Panchshila rendezvous, my patient will just respond within 10 minutes, great going sir. So he is so gratified. So it's just that, it's unfortunate that in this country, the patients are still getting disabled and bedridden, which is, where you can prevent a stage progressing to, I'm not happy I'm getting to do joint replacement, I'm sad, I don't want to operate on those patients. They are young and they are suffering from a preventable problem where a timely institution of, arthritic drugs would have saved them from these.
Sir, my last question to you. In your setup, my last question to you, there will be many questions for you. Sir, what is the cost of a bilateral hip replacement in your setup?
So it just depends on the kind of implant you are putting in. We have all kinds of implants, so usually we have a package which is about 3 lakh rupees plus implant. So that cost of implant is separate, so the patient can choose what kind of implant.
Sir, what should I tell my patient, 65-year-old, bilateral hip, and I am sending that patient to you? So what is the kind of figure that I must give that patient?
So you tell them something like, 4.5, no, bilateral about 6 lakhs.
Everything done, everything included?
Everything included.
Which room, private or double? Semi-private room.
The private.
Right. Dr. Tulsi had questions for Dr. Rajesh Malhotra, sir. We will come to Dr. Dipanjan later.
I have been told that I should specially brace myself and get ready when Dr. Tulsi. Yes, sir. This was the briefing I was given.
Let me say, Dr. Rajesh Malhotra, that was an excellent talk.
Thank you,
and
sir.
We had several questions from our colleagues, and just a few small questions from me. You stressed on the anterior approach versus the posterior approach. What about anterior approach in patients who are obese? See, this is not a good approach in patients who are obese because their abdomen or their bulge would fall on their hips. So this is not a right approach for people who are really morbidly obese. Would you probably consider a posterior approach there?
No, sir.
No.
I would like you to come and observe a case of morbidly obese patient in whom I hope you see his bottom before we go on, whom I operate from the posterior approach. So I sometimes say, yaar CD lagao, niche jana hai. It is so big, right? And let me also tell you, your point is very valid, sir. You have lived up to your reputation. That's a problem. That's a problem. So what we do is that big abdominal planus, which is actually coming onto the incision area, we actually push it up and tape it.
Okay.
But let me tell you, sir, you will be able to understand it very well. To reach a hip from the big gluteal region or bottom versus, they have very little fat in the front. So if I give an incision, I reach quickly inside and there is much less fat. But having said that, there is higher incidence of wound healing problems in the anterior approach compared to posterior approach. I grant you that. So we have done some modification. So when we give the anterior approach, we don't take the incision to the crease, because if you take it to the groin crease, the wound healing complications get worse. So what we do is we go on the top and then I just do cheating and just tilt it a little along the crease rather than crossing the crease, and that reduces. Still, in these patients, the wound complication rates are slightly higher, but sir, it is still a very major issue, because sir, I have done 15,000 by posterior approach and I shifted to anterior approach when I could put a hip in the posterior approach in 20 minutes, and my first anterior approach took 2 hours. As an orthopedic surgeon, trust me, I know when to do anterior. I still do posterior. I have nothing against posterior, but in a group of patients where I think this patient, so a young male or even obese, I have done a direct anterior on a patient with a BMI of 47. 47 BMI I have done, but counsel them that in these patients the wound complication rates are slightly higher. So we take care of that, we know how to do it. When we talk about our obese patients and the patient says, Doctor Saab, मैं बहुत मोटा हूँ, मोटी हूँ, प्रॉब्लम तो नहीं होगी। देखो आप इंडियन स्टैंडर्ड से मोटे हो, लेकिन कभी एक बार न्यूयॉर्क में चक्कर लगाओ, आपको ये दिखेगा आप बड़े कमजोर हो। द अमेरिकन्स आर सो मॉर्बिडली obese and all these surgeries are done in America also, sir, and by the different approaches.
So that was a new learning for us. All along we thought the posterior approach was the best approach.
No sir, it is still the best approach for redo hips, and it's still a best approach for many things. I call myself a circumferential hip surgeon. I can operate a hip from 360 degrees. So I say, ये patient है, what is the best way to give him a hip, which approach? So I'm not a salesman for direct anterior approach. I'm here to tell you that's an advance, because when half the American surgeons are doing it from the front, I don't want a patient to come and ask me, डॉक्टर साहब अमेरिका में तो सामने से करते हैं, आपको आता है क्या?
That's great. Okay, let me proceed further. So, Dr. Malhotra, talking about, you mentioned about outdoor procedures. See, this is a new advance. And advances in surgical techniques, advances in implants, advances in pain management is what you seek here. And I mean, it's very reassuring that you could do a hip replacement and send the patient back home the same day. You know, this is normally not the norm. We keep the patient in the hospital at least for a day, you know, to observe for DVTs, infections and all that. What do you say, sir?
So, sir, two things. So, in America, the reason for doing daycare is cost. Because if a patient stays in the hospital, it costs much more to the hospital. So they send the patient home, and the nurses go there, stitch removal is done there, because it's cheaper. Now, why did we do it in India? Two reasons. One was COVID. When the COVID struck, we thought it was not a good idea to keep the patient. When we started doing surgery again, we didn't know who was carrier, who was suffering, who was not. So in the interest of patient safety, a post-operative patient who's in the ward recovering from surgery, contracting COVID from somebody. So I did this daycare during COVID. But the other thing is, when I worked for 44 years in AIIMS, I had 20 beds in my units. And I was doing 6,000 surgeries in a year. So for Americans, it is money. For me, it's benefiting more patients. So if I can vacate the bed, the next day I can vacate. So I'm operating on Monday, Wednesday, Friday. Operate on Monday, Tuesday that bed has to be vacant for the next patient, so that we can give the best maximum coverage, greatest good of the greatest number. So, and about DVT, the whole world is moving towards fast track joint replacement, which means you do the surgery, it's true about our hip replacements, our knee replacements. 2 hours after the surgery, the moment the effect of anesthesia is over, the patient gets up, starts walking. So where do you give it opportunity to get DVT? Where do you give it opportunity to get chest infection? So only challenge is pain control, which is done much better in hip, because hip is less painful. So we could do daycare and hip replacement much earlier. Knee is a much more painful surgery. So unless we have a catheter in the joint and a pump which is injecting painkiller into the knee, it is very difficult to do daycare knee replacement. I have done daycare partial knee replacement because it's much less painful, but I have done 24-hour discharge, but I have not been able to do same-day discharge unless we have those expensive analgesic pumps available.
Right. My last question to you would be regarding...
Sir, do you mind if I get a drink? Your questions are very tiring.
May I give him a drink? Give him a drink.
Actually, make it large. No, but it is his last question. Make it small.
Absolutely.
Sir,
Absolutely.
you don't intimidate me, sir.
My last question.
Go ahead,
My
sir.
last question,
Go ahead.
Dr. Malhotra, to you would be regarding the future of hip replacements. See, you mentioned about robotic hip replacements. Are you doing that?
Yes, sir.
So how do you evaluate that as compared to the normal conventional surgery? Do you think this is more precise, more accuracy is there, less complications, early discharge, and early rehabilitation also.
Is there a person from Apollo here?
Yes, of course.
Then my
Rick
answer
Tona.
then my answer will have to be different.
Give us forget
So,
about
sir.
Apollo, give us your answer.
So sir,
Future of
the future is never going to be robotic because a technology which is expensive. Robotic is never going to be so affordable so as to be available to everybody in the country, anywhere in the world, sir. Because the current robots are not the final, they are initial generation. Advanced versions will come. So a technology to be universally acceptable has to be cheap and affordable. The modern technology like robots will never be so affordable that it is accessible by everybody, nor there will be enough trained people. So it's like, sir, you drive Maruti 800 and you don't have GPS, you don't mind because you know the way. You can drive anywhere. But if you want to make use of GPS, you spend extra money and you install a GPS. So technology comes at a price and not everybody in the country can afford it. So it is really not the future because select few who can afford Mercedes or Audi or whatever Range Rover will avail of it. Our job is to be providing them that. So if you are a Maruti owner, I'll serve you. If you are a Mercedes owner and you want a GPS, I'll serve you. But having said that, and that cannot be a rule, after doing 15,000 hip replacement, for me, I don't think it's an added advantage. But having said that, back to the thing about American, sir, to robot karna aanda hai? Robot.
I understand it's a learning curve.
We also make steel.
Yeah.
We also make steel.
I understand it's a learning curve, but precision and accuracy probably more achieved with robotics.
Sir, absolutely. You are 100% right. But sir, let me also tell you, the robot and all everything works on computation. And the basic rule is garbage in, garbage out. You plan well, the robot is a slave. He cannot be your master.
Thank you, sir.
You have to do the planning, and if your planning is good, the robot will obey you and you'll get a good result.
Just to relax you, Yogurtna, I have come across was having 522 pounds weight. He was one of those tough cases, as he was saying, for anterior versus posterior. So are you using nerve blocks? As you said that pain is more in knee. Are you using nerve blocks also in cases?
So, sir, that is, I think, he should answer because you see, I never interfere in the job of the anesthetist. So when the patient says, sir, kaun sa anesthesia doge? मैं बोलता हूँ, anesthetist आएंगे. I have only two requirements. One, you should not get pain. Two, you should not kick me because I am trying to do something good for you. So as long as these two things are fulfilled, I don't care what anesthesia is given. But having said that, the epidural anesthesia is the best combined spinal epidural because it's got less complication, less risk, and it has got the potential for pain relief after surgery. So if you have got an epidural in, you don't really need the peripheral nerve blocks. But if a patient for some reason cannot be given the spinal anesthesia because of spine surgery, instrumentation, stenosis, then it helps to give the peripheral nerve blocks. But we don't want motor blocks because in Mayo Clinic, one knee replacement patient broke his femur because they gave femoral blocks and mobilized. He was trying to walk, fell down and broke his femur. So we want purely sensory block and no motor.
So my last question is, it was very rather challenging for us. It is still challenging to write generic versus branded. What about your brands, about the devices you are using for the hip replacement and all? Because it may come, it has come for the cardiac people, for the stents. There were some bioabsorbable stents which have been, I think, withdrawn because there were no buyers, because there was some caveat from the government, not more than this, not less than this, anything facing like that?
So sir, again a great question, and I agree with you. The future is that we will all be forced to go for Make in India. Now, I don't have nothing against Make in India, provided I can be guaranteed about a quality assurance, because sir, joint replacement is not a surgery. I just mentioned in the passing, a redo surgery has got minimum 5 times or maybe up to 10 times higher risk of complications. So we see infections, we see fractures, we see osteolysis, and I can tell you, a well done surgery can last 30 years. So what have you saved if a patient gets failure early? So I don't think this is, so I'm not saying I'm not an agent for imported implants, but I want my indigenous implants to be as good as imported ones, and there are ways to prove that. In 1 year, whatever you walk is equivalent to 1 million cycles of testing. So you show me 20 million cycles, this joint is good. It means this joint should last that person 20 years. And then I'm happy. There's no problem.
Thank you so much, sir. Actually, it was very... sir, any questions from...
I think question answers to Dr. Rajesh Malhotra sir have ended. Sir, we give you a big hand for answering all the questions so beautifully. Displayed your skills on hip, and we are waiting for another CME to see your skills on knee. I am always very greedy to have one more CME, sir. Dr. Dipanjan is an excellent oncologist. He gave a beautiful presentation on immunotherapy. What I learned from him in the entire presentation was that his love for his family stood out. And he came from there to India. I would have done the same thing. Everything from his studying in US and in AIMS, going back to his mentor in US, is actually wiped out. So I have some very simple questions in my mind for you, sir. Sir, is immunotherapy the future of oncology? Kindly answer it. Is immunotherapy the future of oncology?
I think medicine is an ever-changing subject. So what seems to be a future now will be a past after some time. Having said that, this particular type of medicine has definitely opened up a new vista. But like any other medicine, any other ways, we need to use it judiciously. It is not for everybody. Not every patient benefits from that. So as Professor Malhotra sir has rightly pointed out, any technology, any medicine, everything is only beneficial if you know how to use it. So I have a chef knife, I sometimes cook. So you can do a very nice cutting with that chef knife, but you can also cut your fingers. It all depends on your skill. So when people talk about AI and everything, what you feed, if you garbage in is garbage out. So as you sow, so you will. So no, it is not only the future, but it is definitely a new vista which has potential to benefit oncology in particular and medicine in general.
Sir, immunotherapy has varied prognosis in varied malignancies. It's one of the fields where immunotherapy has been shown to have very encouraging results, even in stage 4 cancers, is lung cancers. I wanted to know how much prognosis has it changed in lung cancers, in stage 4 cancers especially.
So I think in one of the slide I have shown you that in stage 4 lung cancer, the average 5-year survival was less than 10%, and till 5 years back we used to give the roughly rule of thumb, it was around 12 months to 18 months. Now that has changed. Now even in stage 4 lung cancer, it responds well. The 5-year survival is in the tune of 31 to 33%. So the median survival has roughly doubled.
Sir, in your own practice, and you must be practicing immunotherapy,
what is the longest surviving stage for lung cancer?
So that's a good question. So first of all, we are using immunotherapy roughly since 2020, late 2020, and it's not a cheap option, it's quite an expensive option. So I think I have two patients. One is a 32-year-old engineer, and he got lung cancer with adrenal mets. He was 32. He's got just married for 2 years. He has, in fact, his daughter was 3 months when he was diagnosed. And at that time, Leela Gandhi's paper on pemetrexed carboplatin and pembrolizumab was just published, I think, 3 months back in NEJM. So the drug was just brought to India by MSD. We used that, and he's still surviving. So it's been more than 3.5 years. And when initially we treated him, after 6 cycles, his company NTPC refused him support because of the cost. Then we continued him only on chemotherapy. But to our surprise, the cancer not only disappeared, but it continues to remain well. So that's the question. That's why I brought up the issue of memory T cells. So I think it will be right, it will be 48 months or so now. But again, I would like to reiterate very humbly, not all patients respond like that. It's simply, I mean, I can give you a crude similarity. If you have purchased some 10,000 shares of Infosys in 1990, or 5,000 shares of SBI, or maybe a 10,000 share of Reliance in their IPO, you and I need not to work. But at that same time, many people have invested in many other shares which has gone bust. So if you look at the criteria, about 20% of people do very good results, but 20% may not. And there are some issues of hyperimmune reactions. The cancers may actually increase. That happens in 5% cells that we don't discuss as well, but there are issues. So they are not without pitfalls. But having said that, that does not take away the response issue.
Sir, one of the commonest cancers in our country is breast cancer.
Yes.
Are you using immunotherapy in stage 4 breast cancer?
So that's a great question. In fact, if you roughly divide breast cancer, there are 4 types: luminal A, luminal B, HER2 positive and triple negative breast cancer, which have no hormonal expression. For triple negative breast cancer, we are now using immunotherapy, and it has shown great result, both as a neoadjuvant therapy in an operable cancer, as well as in metastatic breast cancer, but only in that subset of patients which are triple negative.
Dr. Dipanjan, in triple negative, is it imperative to use immunotherapy in all patients as adjuvant? Because I have seen many oncologists get immunotherapy in adjuvant before operation.
So neoadjuvant.
Neoadjuvant.
So there is a recent paper which was published which has shown there is a 10 to 15% improvement in pathological complete response when you use it as neoadjuvant. Now what we get by pathological complete response? That when you are acquiring neoadjuvant chemotherapy, that is before surgery, you use the medicine to shrink the tumor. Now, by pathological complete response, we mean when we do the operation, in surgery there is no residual tumor is seen. Now, whether a pathological response will lead to higher survival has not always been proven. But having said that, you must understand, unlike hormone positive breast cancer where you have hormones to treat after you complete the surgery, or in a HER2 positive breast cancer where you have a target like HER2 which you can do, in triple negative breast cancer beyond chemotherapy till now we had nothing, and they are the most aggressive cancer. So that is why when we see that adding immunotherapy gives you another 10% to 15% in pathological response, and it has been shown that also in an overall survival. So yes, that's an added advantage. You can use it, but considering the cost, it cannot be prescribed for each and every patient in India. In fact, I have started using immunotherapy of breast cancer only recently, because there is a cost. But the cost is decreasing. Gradually the companies are coming with a better patient support program, but it still remains in it.
And the immunotherapy agent should be pembro in most of
No. Absolutely. There are 5-6 immunotherapy agents 2-3 of them is PDL1 inhibitor, 2 or 3 of them is PD1 inhibitor, and one is CTLA4 inhibitor. So there are different trials, and not all immunotherapy has shown equal response in each trial. So basically, when you are using some particular drugs, you are using some evidence to use it. Like in hepatocellular carcinoma, there is a drug called atezolizumab which has shown better result, but the pembrolizumab did not show. In lung, the pembrolizumab showed a better result. In stomach, it was the nivolumab which showed better results. So it all depends on, and you can always argue that this trial was not done properly. There are statistical biases, but at the end of the day, since we are practicing evidence-based medicine under code, so-called evidence-based medicine, so it is a major publication which will drive your practice.
So if immunotherapy was not given at neoadjuvant, can it be given with chemotherapy post-operation?
Well, it can be given or administered, I would say. But the question is whether it will be the equal benefit or not, that has not been proven. So in breast, I think you are talking about breast cancer.
Yeah.
So in breast cancer, the treatment regimen which is accepted is in perioperative therapy, that you give around 8 cycles before surgery and 9 cycles after surgery. So it has not been proven whether you give it after surgery. Unlike, there is another drug called avelumab which is used in metastatic bladder cancer, in bladder cancer, where we have seen that post-surgery we can use it as an adjuvant therapy and it has shown response.
Dr. Mangla sir has a question.
Okay.
Yes, sir.
Regarding lung cancer, I am a pulmonologist. Most of the patients 2 years earlier.
Yes.
One of my patients, whom I diagnosed in 2008, died about 3 months back. And I had seen him, he was doing pretty well. And later on, finally he was on pembrolizumab. But I am saying that patients of lung cancer with recurrent pleural effusions, do you have experience that if they are given this immunotherapy, how does the pleural effusion behave?
Sir, I have not in lung cancer, but I have a response in a Hodgkin's disease. So this girl was a 32-year-old lady. She was initially diagnosed with Hodgkin's lymphoma. She got 1 or 2 cycles in TMH and then referred. We are very happy. They say germ cell tumor and Hodgkin's lymphoma are 2 cancers with highest cure rate, and we all like to treat. But what they don't say, if the Hodgkin's lymphoma is refractory or relapse, it is one of the most difficult. So this patient didn't respond to ABBD. We give BCOP, which is another treatment. And this patient developed a recurrent pleural effusion. And every second or third day she used to come and she becomes so desperate. And she has a small insurance of 5 lakhs which got exhausted. So in desperation, I sent them to All India Institute, my alma mater, to my teacher, Professor Atul Sharma, who has just taken VRS to join maths. And my junior Raja Pramani saw, and they planned for a transplant, but for transplant they first need to give, transplant is not an panacea. They need to bring down the tumor only, then do the transplant. Patient was even not responding to second line salvage therapy. So they gave her some nivolumab. Now that drug was also bought for some other patient who did not need it. It was a CGHS patient. They donated the drug. And that pleural effusion was completely gone. Nivolumab is a standard drug in Hodgkin's disease, post-transplant for maintenance. But after seeing that, seeing is believing. She is one of the rarest of the rare patients whom I actually went to her house in Faridabad. She was referred to me, one of my classmates who's same concern. I generally don't home visit anybody. But that young girl with a 5-year-old son, it was very difficult for me emotionally. And I was so happy. And she didn't have the money to afford immunotherapy, but somehow my colleagues at All India Institute had managed to fit. The credit doesn't come to me. I was only able to refer them. And being an ex-alumni, they usually respect your seniors. In medicine, that is one good thing. That if your seniors say so, wherever you are, whoever you are, you try to So that response. But in lung cancer, but you see in lung cancer, not always all effusions are malignant effusions too. Sometimes there are other issues. In fact, in RECIST criteria, response.
Saying proven malignant effusion.
Sir, I have not, this
particular one I have seen, but this is not lung. I do not have any particular issues, but generally if the response is there, it also responds. But as of now, I just can't bring out.
Just last question. 80-year-old squamous cell carcinoma, stage 4. Now, this patient, PD-L1 negative, is it still worthwhile giving him immunotherapy?
So only then I was discussing this with one of my colleagues who was at Already Institute and now gone back to TMC Kolkata. So the paper shows if you CT, we call it a combined positive score, CPS. If it is more than 1, you should be giving it with chemotherapy. If it is more than 15, pembrolizumab, you can give it alone. Now, the data of less than combined positive score 1, but they calculate the total number of PD-L1 positive tumor cells divided by total number of all PD-L1 positive cells and multiplied 100 is less than 1, the data is not very clear. But having said that, it is also proven that PD-L1 is not the only biomarker. There are other biomarkers like tumor mutation burden or TMB, which is more than 5. And PD-L1 is not infallible. So since squamous cell cancer do not have much second line, third line, fourth line, and their mutation study is really low, I think if the patient can afford, it's still worthwhile to give immunotherapy. But yes, the question is that in those cases, you need to discuss and explain the patient that the quantum of benefit may be less. But since we do not know the exact biomarkers beyond PD-L1, there can be other biomarkers. The general idea is that if you have to give and the patient can afford, it's better to give.
Dr. Panda, Dr. Tulsi sir has a question.
I know, sir. It has to be there.
Thank you, Dr. Dipanjan. So that was a wonderful presentation. So is immunotherapy precise medicine? See, well, for some, maybe to 15 to 20%, this could be a precision medicine. But for many, the great irony of modern oncology is this isn't precise, this could be imprecise. Having said that, the biggest challenge for cancer immunotherapy is its inability to predict its treatment efficacy. What do you say, sir?
You're right. First of all, so-called precision medicine in my understanding is not that precise.
Right.
It remembers one of my mathematics teacher has once told me in our class, in class 12, that in his master's, one boy was in his paper was jumping steps and saying, so it is very clearly visible, it is very clearly understood. So after that he cut him a 50% marks and in bold letter wrote, all clearlies are not so clear.
Right.
So you're right, the precision medicine is not that precise.
What's the right dose, right patient, right duration? We don't know.
No. So how these dose and duration happens, that is something I learned at USA, and the indication also. So you know this phase 1 trial, phase 2 trial, they decide on a particular dose about the maximum tolerable dose and minimum toxic dose or something like that, and they ultimately come to a dose. Like for rituximab, we use 375 milligram per meter square, but it has been shown that it can go even 500, 600, 700. So for immunotherapy, it has been proven that only 20% of the patient does respond. And although PD-1 and PD-L1 positivity has shown to be one of the positive predictive marker, but it is not infallible. They have also used tumor mutation burden of another marker, microsatellite instability of another marker, but we are still learning, and I would say we are still on the curve.
Most of the time we are using this in stage 4 end stage cancers, but early immunotherapy in lung cancers, probably also in triple negative breast cancers, can be game changing.
Well, that I would say in all cancer, this things, any treatment starts with the stage 4, then move to adjuvant, neoadjuvant therapy.
No, sir. You're talking about early lung stage cancers, early triple negative breast cancers.
That's what I'm trying to tell you, sir. Any cancer therapy, when you look at their trial, they started with the worst case, like the stage 4 patient.
But
once
now,
they showed response in stage 4, then they start treatment. As a whole, we are shifting our medical treatment to a neoadjuvant or early treatment.
Right.
Because I'm saying if you have to give it,
it's better to give it early than late.
Thank you, sir.
Have I been able to answer your questions, sir?
Absolutely, all of them. But we'd like to have more questions.
Dr. MPS Gandhi sir, last question.
Sir.
So a patient is on terminal lung failure and may not be a lung cancer. Immunotherapy does have any role, or lung replacement will be the other option?
Sorry, sir, can you come? Which lung?
Patient who is having terminal lung failure.
For what? Like
for any other thing, maybe because of cancer, maybe because of any other problem. So the treatment is immunotherapy has got any role?
Immunotherapy is not panacea. Even if it Amrit Kal, sir, it is not Amrit.
And then lung cancer, only the replacement will be the option.
In indicated cases, lung replacement is definitely a treatment, but I am not a qualified guy to reply on that. Immune checkpoint inhibitors has a very particular precise role, and one thing we may do by overusing and abusing it,
Sir, last question. I am Dr. Immunotherapy. Recently in England, there were patients who were suffering from HIV, and they were having cancers also, and they were treated. They were given some anti-cancerous medicines, and now their HIV status is negative. Sir, your say on that, because there are patients who come to us who are immunocompromised. If a patient is having CD4 count which is less than 50, 30, 20, and definitely they are having secondary infections, including tuberculosis, including cancers. My question is, sir, in England there has been a trial, and 5 patients have been put on the medication and they have been put on the anti-cancerous drugs, and their HIV status is negative. Sir, any say about that?
So, I am not sure and aware of this particular study, but let me answer. HIV-associated cancer is a whole chapter in a textbook of oncology, starting from Kaposi sarcoma to high-grade lymphomas. Cancer itself is an immunosuppressive condition, so is HIV. Generally, in a high-grade HIV-associated lymphoma, we treat them together. With anti-HIV medicine, either a doublet or triplet medicine, we start cancers. There are some medications in like rituximab, which wipes out the B lymphocytes. We are careful. We first start them on anti-hepatitis B treatment, and once the HBV DNA is less than 100, we only add the rituximab. Less there is a reactivation of virus causing liver failure. But if the cancer burden decreases, patient's immunity improves. Whether that particular improves in immunity also leads to decrease in HIV burden is a theoretical possibility, but I am not an expert on infectious disease.
Sir, my another question is that if a patient comes to us with a CD4 count of 10, and we are putting on the patient on anti-HIV drugs, the CD4 count immediately after 3, 4 or 6 months increased to 400, 500, 600, even sometimes it goes to 1500.
Sir,
my question is, sir, that should there be any study together with the HIV specialist, and if we put the patient, for example, patient is suffering from cancer, and can we put the patient on anti-HIV drugs so that the CD4 count is increasing and we
But of course, in a cancer patient who is HIV positive, it is pertinent, it is imperative you give him anti-HIV drug along with cancer drugs. You cannot...
Sir, my question is not for HIV patients. My question is that if we can do a study
But you want
that
to give
if a
cancer
patient is
anti-HIV drug.
because the problem is that what is the cause of the death in the patients of who are suffering from cancer? It is only CD4. The CD4 is going down, and the patient dies.
So you are saying that if I give anti-HIV drugs, that CD4 will increase. Well, that's an interesting postulate.
Sir, but sir, this is happening. This is happening. This is what I mean to say. That a patient, when he is having CD4 count 15, 20, even less than 10, and when we are putting him on the
your point. I think that can be an interesting postulate, that giving anti-HIV drug to improve the CD4 count so that patient immune system improves. And yes,
Dr. Rana, can we thank you so much. I think we had a wonderful session. We need to give a big hand to Dr. Rajesh Malhotra, Dr. Dipanjan Panda, our moderators, Dr. I.K. Batra, Dr. M.L. Kandra sir, and a very, very special person I invited today for your introduction, Dr. Hiremat, the person who is a master of aorta. He didn't leave. He will have his dinner with us. I am extremely grateful to you for staying that long, for asking some